That is plenary session, top 10 texts from Iracon 2022. I am Dr. Rahul Sahu, rheumatologist from Bhopal, and I would like to invite Dr. Narsimulu ji sir for chairing the session. He is consultant rheumatologist at GVN Medical Center at Hyderabad, and Dr. Rajendra Illapati from Rajendra Varaprasad Illapati from Yashoda Hospital, Hyderabad. Also, I would like to invite the speakers, Dr. Ashok Kumar sir, Clinical Director at Department of Rheumatology, Fortis Hospital, Delhi, and Dr. Lisa Rajshekhar ma'am, Professor of and Head of Clinical Immunology and Rheumatology Department at Nizam's Institute of Hyderabad.
Good afternoon, my friends. I think we are coming last part of the Iracon 2022, and many have gone home. Still, some are very enthusiastic. They are with us. In this, with me, my co-chairperson, my colleague Dr. Varaprasad, and Dr. Ashok Kumar, and Dr. Lisa Rajshekhar. And in this session, this plenary session, very important. Last 3 days, what we have learned, what we have not learned, and what we are taking home. It is divided into two parts. One is clinical, other is basic. The clinical one will be dealt by my colleague Dr. Ashok Kumar. I need not introduce him. I don't think anybody doesn't know him in IRA. Right from IRA initial days we were working together. He was Professor HOD, Rheumatology Immunology, AIMS, and after retirement he was practicing at Delhi. Dr. Ashok, kindly tell us top 10 messages of clinical from Iracon 2023.
Thank you,
22.
Dr. Narsimlu. After listening to such brilliant talks this morning, I really feel intimidated. I don't know whether I'm the right person to make any kind of assessment of what are the top 10 talks in this entire conference, which has plethora of presentations. As mentioned yesterday by Devashish himself, that there were 450 platform presentations and there were 400 posters. So if you add this number, out of this, how do you choose which are the top 10? Certainly I cannot. And whatever I present might be completely irrelevant to most of you. Am I not audible? Okay. So actually when Devashish asked me to give this kind of talk, I was most reluctant. I said, no, how will I prepare the talk? Where is the time? You have so many presentations, you want me to miss much of them? If I prepare slides every day? He said, no, I will provide you a team of youngsters who will be sitting in all the halls, at least there will be one person posted in every hall. You know the number of halls that this conference has. Anyway, everything looked completely a daunting task that I would not be able to do. Still, he said, well, I am giving you respect, you see, take it that way. I am choosing you to do this presentation. I said, it looks impossible to me, but if you say so, I will not like to sort of back out of it. Okay. I will try my best. And to tell you the fact, I made these slides only this morning. I have been passed on a Google document where these bright youngsters have been, writing their understanding of whatever the lecture was about. And they were told to write 1 or 2 line summary of each talk. And when I looked at it, I thought, it's not possible. I got up at 4:30 in the morning, started making 1 or 2 slides, and then I realized there is not enough time. So anyway, with all that background, and with the thanks that are due to the people who have worked and made all the notes, I would like to begin. So I have written a few names. I'm sure I might have missed out some names, and these are the people who have been actually taking notes. So I've just listed a few, and you may like to listen to what I say, but please don't think that this is kind of some judgment or this is some objective kind of evaluation. It is not. It is just a random pick, and also convenience wherever I had something to say. So let me talk about the first presentation. This was by Dr. Inoshi Atukorala from Sri Lanka, I think. Determinants of pain and pain flares in knee osteoarthritis. So what she said was that a shift from agricultural to industrial age without a change in diet has led to an epidemic of obesity. High prevalence of normal BMI, but high fat to muscle mass in South Asia. Very relevant statement. And she did a study to predict pain flares in osteoarthritis in Sri Lanka. Found some factors like knee buckling, knee injury, increased physical activity, footwear having some problem, and poor mood. These were the things that she found. But the interesting observation was that walking barefoot had a protective effect on flares of osteoarthritis. The second talk was by my colleague Dr. Rohini Handa, changing scenario of outcome in RA. Now you can see, these are talks in which I could relate myself, and I felt a little impressed that, okay, this is relevant to me. It doesn't mean that it might be relevant to everyone. Paradigm shift has happened in the management of rheumatoid arthritis in the recent past. Symptomatic relief has progressed to disease modification, and then now recently drug-free remission. So there are improved patient-reported outcomes, improved disease activity, and decline in radiographic progression with existing treatment. Inpatient costs have come down, surgery volumes, orthopedic surgery volumes have come down, there is evidence, and indirect costs like work disability, absenteeism are still significant. That's an important observation. The third talk which I was very impressed with was on gout by Binoy Paul. I always felt that he comes up with more information every time you listen to him, and I think he's a master in this field. So according to him, EPLA 2021 guidelines for treatment of gout are most suitable for India. All of us should go through them. There has been a 2 to 3-fold increase in global incidence of gout in the past 2 decades. Allopurinol, which many people hesitate to give in chronic kidney disease, is not contraindicated. ACTH and rasburicase can be tried in refractory cases. There are many new drugs which have become available outside India, but in India, topiroxostat is the one which is available. And the last statement is that newer drugs acting on urate transportomes are under development. And he did spend quite a little bit of time on transportomes in the causation of gout. Then a paper on antiphospholipid syndrome in 2022. Avinash Jain, who spoke on behalf of Ranjan Gupta. Triple positivity and presence of lupus anticoagulant lead to poor outcomes in pregnancy. This was emphasized. Steroids have no role to play for obstetric indications in APS because of increased chances of PIH and fetal growth retardation. The drug of choice for anticoagulation in APS is warfarin, not the DOACs. The DOACs associate with risk of arterial thrombosis. Should be avoided unless warfarin is contraindicated. A brief scleroderma update, Dr. Gitabali, Sircar. Nintedanib and tocilizumab prevent the annual decline of lung functions in scleroderma. Rituximab improves both lung functions and skin scores in systemic sclerosis. Tofacitinib may be a novel targeted molecule both for the skin and digital ulcers. And lastly, combination of immunosuppression and antifibrotics could be the better option for Scleroderma ILD treatment today. Then this talk on steroid-free remission in autoimmune rheumatic diseases by Dr. Parashar Ghosh. In non-renal lupus, steroid-free remission and even drug-free remission is not uncommon. In lupus nephritis, however, tapering steroids off is controversial. And in rheumatoid arthritis, the steroid bridge is too short. 3 months of therapy may not be sufficient. Then this talk that was given by Rajeshwari on the year that was in rheumatology. So the first statement, MMF can help reduce the immunogenicity of pegloticase in gout treatment. This was one paper that she cited, and this was the summary. Then think of gout in refractory cases of psoriatic arthritis who are not improving. Serum level may not help, but ultrasound can be useful tool to detect this. The 2021 GRAPPA, the conventional synthetic DMARDs are highly recommended as first line for psoriatic arthritis, and those who are inadequate responders to conventional DMARDs, TNF inhibitor, IL-17 inhibitor, IL-23 inhibitor, and JAK inhibitor. Any of these is highly recommended. TNF inhibitor and IL-17 inhibitor are comparable for peripheral arthritis in this group. There is a need for frequent ophthalmic screening in HCQS therapy even before completion of 5 years of treatment. Now this paper she did cite, but I personally don't agree absolutely. I feel that the current recommendations that we use, that in the first 5 years you don't need any monitoring, only after that you start doing it annually. And personal experience also, is against this kind of conclusion that it is such a risky thing to give HCQS and in the first 5 years without any monitoring. Now, this talk by Dr. Sahana Baliga, do I treat osteoarthritis as an inflammatory disease? Well, treatment of osteoarthritis remains a work in progress. Inflammation in osteoarthritis is low grade and chronic. A whole lot of new therapeutic agents have been tried without success. This summarizes osteoarthritis in one line. Targeting people with early pre-radiographic osteoarthritis and early screening of people with risk factors holds promise. But as I said before, it's a work in progress. Chronic musculoskeletal pain, there was a session where Dr. Malviya, Dr. Sam Whittle, and Dr. Sunita Kayanidhi were participants. So the key statements that I chose in this are that there is a need for differentiating nociceptive from nociplastic pain, or the third pain. Every patient's perception of pain is different. Fibromyalgia is a description, not an explanation. Fibromyalgia is best considered from a systemic perspective. It's an individual experience with common elements. Opioids, benzodiazepines, and cannabinoids are best avoided because of the high incidence of adverse effects and not much benefit. Multimodal therapy is the way forward. And then, can we prevent RA? As we know, multiple sequential steps lead to autoimmunity, preclinical phase, clinical, and then finally overt disease. Smoking and air pollution play an important role in the pathogenesis. All of us are familiar with this concept. Triggering of autoimmunity against post-translationally modified antigens can either occur in lungs or in the gums. And ACPA, AMPA have multiple specificities and predispose to RA. Potential does exist for a drug-based prevention of RA. But again, this is a work which is still going on. Then a few statements about pediatric lupus. There was a session, and Dr. A.V. Ramnan from the UK. In his talk, this summary is relevant to us. Pediatric lupus, according to him, has a mortality as high as 10%. 50 to 100% of patients in India have lupus nephritis in children. It is important to do a biopsy, kidney biopsy, even if difficult, as it helps you prognosticate. 75 to 80% class 2 lupus nephritis may transition to class 3, 4 or 5. 33 to 40% of class 5 may transition to class 3 or 4. And 80% of class 3 and 4 will remain as such, will not move. Rituximab, in addition to MMF, is good option in refractory pediatric lupus. It saves cyclophosphamide for particularly difficult or refractory cases. Then this presentation given by my friend Colonel Uppal, I don't know whether he's here, he might have gone. He talked about sarcopenia, a crucial bone health related issue. Now there are established diagnostic criteria for both osteoporosis and sarcopenia. Presence of one should prompt evaluation for the other, because often the person has osteosarcopenia, both bone and muscle. In patients with autoimmune rheumatic diseases, we should consider possible aggravating factors for both osteoporosis and sarcopenia, like vitamin D deficiency or glucocorticoid excess. And what is suggested as a kind of treatment or prevention is increased physical activity level and adequate protein intake, 1 to 2 grams per kilo per day. But actually again, there is no proper solution available at present, and this is again an area where a lot of work needs to be done. So, osteosarcopenia. Now, obviously, this is not something that will suffice. Probably instead of 10, there should have been 50 top papers that should have been covered. But this is what I could do, and even I can see deficiencies here. Today's sessions, obviously, I couldn't have covered, and today there were some really brilliant, lectures. So I would like to stop here, and I don't know whether this session also has provision for questions. I think I'm done. Thank you.
Thank you, sir, for that excellent lecture. I'm sure everyone would appreciate your talk, because you have summarized all the talks and along with your valuable comments. If there are any questions, please. Yeah, please, sir.
And audience, if you feel like my friend Ashok misses on message giving, kindly feel free to share.
It's actually it's a plea and begging for something. This summary was wonderful for many of the sessions that I attended, but I would be very grateful if it was possible to put on the site of IRA all the other sort of sort of topics that has been covered. Because they are brilliant summaries of all that we couldn't take notes sometimes from them. If it was possible,
Thank you.
That would be nice.
Anybody else? No.
Thanks.
Thank you, sir. It's my pleasure to invite Professor Lisa Rajshekar, Head of the Department of Disaster and Medical Sciences, who doesn't need any introduction. Everyone might have listened to her debate yesterday. Madam, please. Madam will summarize about the basic and translation part of the conference.
Thank you, Chairperson, for inviting me to the stage, and thank you, Dr. Handa. And I feel as intimidated as Dr. Ashok Kumar, even more, because as a clinician, to summarize the basic and translational takeaways from this wonderful conference was a challenge offered to me by Dr. Debashish, and like a fool, I tread into that challenge. But I think it has been a wonderful experience trying to look back at the conference. I was late for the conference, but looking back at what had happened before I reached and during attending the conference, and then looking at the wonderful effort. I was told 25 people were working on, enabling us to give away some takeaways to you. And the acknowledgements which Dr. Ashok Kumar has shared stand for my talk too. And in addition, Dr. Ritushman, Dr. Soumya, and 2 more residents from Medical College Calcutta, one doing a DM and another one doing his MD, whose names I'm sorry I've forgotten, have also helped in this talk. So a big thank you for all of them. I have organized this talk not as well as Professor Ashok Kumar, because I was more deeper into trying to understand the mechanisms, pathways, and then finally coming up with what I thought interested me most, and with a probably futuristic thought of what would be of interest in the next few years also for this audience, who will probably repeat their attendance at the next conference in Hyderabad and then in Bangalore. So I was impressed by the amount of basic and translational discussions which happened around osteoarthritis, and this was spread across many talks. And please excuse me if I do not quote the names of the authors or the speakers. That is simply because of my ignorance and lack of confidence that I'll be able to take their names correctly. But they will all be present in your scientific program handbook, which I think is a document worth preserving. So one of the main speakers spoke about the possible therapeutics which are coming up in OA, a field which looks dead to most of us, but which has definitely found, people who are, brightening up the fire in India and abroad. And among them, prominently among them, are Dr. S.K. Das and Dr. Abel Lawrence. And what they showed us was that the sympathetic nervous system is overactive in osteoarthritis. And there was a disconcertant note where somebody in one of the sessions said that the vagal nerve stimulation is very important in osteoarthritis. So this is something you can take home and read. But the TRP1 sensory neurons also have a high role in OA, and the different molecular mechanisms which start acting once the cells within the joint, they start aging. So senescence and prevention of senescence with the help of senolytics was another theme which was talked about often. And senolytics, basically when the cell starts aging, it takes up a different phenotype, a secretory phenotype, and inhibition of this secretory phenotype. The secretions include matrix metalloproteinases, which destroys the cartilage, etc. The 2 main molecules which were heard again and again were the microRNAs as well as the ADAMTS5. And along these fields, therapeutics have been developed, including 1 anti-nerve growth factor antibodies, which have been tried in phase 2B studies and have shown to improve pain in patients with grade 2 and grade 3 OA. And this study has done up to 26 weeks of its tenure and is expected to move on for longer studies. There was talk about denosumab and colchicine as considerations for therapy in OA, but I don't think that these will be heard again and again in the future. So we heard that we already have DCGI approval for use in humans of stem cell molecules, and even the name was mentioned. And this approval came after positive results were seen on chronoprotection in mice models, and then efficacy demonstrated in what I heard was about 100 patients in the last 2 months who have received this molecule, and which is now available in the market. Of very great interest was what was talked about lupus in this conference, and there was a talk about monogenic lupus, which reviewed the more than 30 genes which have been implicated, and most of them belonging to the type 1 interferon pathway, implicated as monogenic genes in lupus, which in children. And what was interesting was that autoantibody levels, they precede the development of high interferon alpha activity. And this is a field which I think will find more and more discussion in the future conferences, because interferon antibodies are also believed to be elevated in patients with lupus, and the interferon pathway itself is activated. So which comes first or second will find definite research in the next few years. The CD38 positive T cells, which are long-lived plasma cells, were discussed. Their mitochondrial function was discussed, and their role as biomarkers in lupus and vasculitis was also discussed throughout the conference. Dr. Pankti, who has worked on differentiating infection and flare in lupus, came back with the concept that TLC and CRP remain the most important biomarkers. However, she hinted that CD8 positive high CD8 cytotoxic C cells may be a useful marker. But again, as seasons come and go, these markers come and go, so we will have to really keep looking at literature in this field. Dr. Amita had a great talk before the start of the main conference on the top 10 papers in the basic field, and she chose papers from Indian scientists as well as international fields. And she talked about two molecules which she thought was very interesting. One was the CD6 alchem pathway in SLE. So again, this is a ligand receptor pathway, and there is a very good paper which shows that this pathway is overactive in mice models of lupus nephritis, and hence the proposition that blocking this could have therapeutic value. Now, what was exciting for a lot of basic scientists, and this was talked about before the meeting and during the meeting, was the demonstration of, in a paper in Nature, I think, that a TLR gain of function mutation caused SLE in a patient. And why a single patient was picked up was because this gain of function mutation, a missense variant in TLR7 in one patient, and in similar variants in other patients have been demonstrated to cause lupus. And basically TLR7, as you know, is a guanosine sensing endosomal receptor. And since guanosine is a nucleic acid, so you can see the links there. And the downstream molecule of TLR7 is MyD88. And when MyD88 is knocked off, then autoimmunity does not develop. So TLR7 blockade and MD88 blockade are possible future targets in lupus. It was mentioned that the JAK inhibitors failed in lupus because they inhibited IL-2 signaling, and we know that low-dose IL-2 signaling, low-dose IL-2 therapy is now being used in lupus. A very interesting concept which was told in this conference, at least it was new to me, was the use of anti-P-selectin glycoprotein ligand antibodies for APS. And what was surprising was that this P-selectin is upregulated on neutrophils, and neutrophils were touted as promoters of venous and arterial thrombosis in a paper which showed that this was happening in a mice model, so that the neutrophils, when they were inhibited with this antibodies, they could be used as targets for APS therapy. And obviously, and the very exciting report which we all must have read in Nature Medicine about the use of anti-CD19 CAR T cells in patients with lupus. 5 patients of lupus who had very refractory lupus were treated with chimeric antigen T cells directed against CD19, and all 5 patients who had very severe disease went into the DORIS remission criteria. All of them, I mean, without exception, and this is an exceptional result. And not only did they have clinical remission, but the antibodies were lower, fatigue was better, the proteinuria was better, and even the complement levels improved. Now, the side effects of this therapy were mild. They included, as expected, a cytokine release syndrome, but only one patient needed tocilizumab for improving the cytokine release syndrome. So this is an area which will excite a lot of us, and we will hope that it will very soon enter into a phase 2B study and then into larger studies and very soon reach the Indian market. Sjogren syndrome was discussed also quite frequently in the conference, and Dr. Bukala said that the group of Sjogren's patients who do not fulfill the criteria, the latest criteria for Sjogren's, because they don't have anti-Ro antibodies in the serum, may have anti-Ro antibodies in the salivary pool, but he was also not sure whether these antibodies are stable. So this was an important takeaway from his talk, suggesting that this is a new finding for them and that they are yet to do longitudinal studies in this area. But he did talk about seronegative Sjogrens and how to go about by the help of deeper histopathology and immunochemistry to make a diagnosis of Sjogrens in the absence of a patient with dry eyes and dry mouth, not having anti-Ro antibodies and having extreme fatigue. So seronegative Sjogrens was an area of interest. Mitochondrial dysfunction is an important concept in rheumatic disease nowadays and is specifically mentioned in inflammatory myositis as a non-immune mechanism of muscle weakness. This dysfunction was also discussed in Sjogren syndrome, where evidence was presented and was suggested as a cause of non-response to immunosuppression. So we are looking at different diseases telling us the same story, that when immunosuppression plateaus to produce further therapeutic effect in the clinic, then maybe there are other mechanisms which you cannot target with the help of immunosuppressants, and you might need other drugs, maybe like rapamycin, etc. So Dr. Ingrid had a course, had a lecture in the advanced course in myositis and suggested that phenotyping T cells in muscle biopsies may help to understand molecular mechanisms. And she said that TIF-gamma, when it is expressed on cells, especially on cancer cells, may be the driver for inducing antibodies which lead to muscle weakness and announce the presence of the cancer in the patient. But the diversity of immune response which we all have may be the protective mechanism which prevents cancer from developing but allows myositis to develop, so that in some patients of myositis who do not have cancer, you may have deletion of the interval cancer cells with the help of the autoimmune mechanisms we all have. So the immune surveillance for naturally occurring cancer cells. Professor Ashok Kumar referred to this lecture, and this lecture actually was sort of a backbone for the next lecture by Dr. Lars, where he said that the fossil fuels which we use extensively, they drive climate changes, and this especially by the release of noxious substances like carbon monoxide and other nitrates which lead to the oxidative pathways and change antigens, and so lead to autoantibodies and their strong association with the development of clinical disease. And he also showed data that the dose interaction of a shared epitope, the gene, as well as these noxious stimulus like carbon monoxide, so differential presence of carbon monoxide in different areas, some which have higher air quality index and some which have lower air quality index. This dose association dramatically increased the risk of a clinical evidence of disease. Dr. Amita again talked about her own paper in which they have studied IL-36 in patients with enthesitis related arthritis and shown that patients with SPA, they studied one of the cells, I forget which, the synovium, the synovial fibroblasts, they are very active, they respond more to IL-36, and she extrapolated this result to the fact that two IL-36 receptor antagonists are in the market, they are already drugs which are discovered, and they may be useful in treating refractory cases of enthesitis related arthritis, which I am sure all of us have in our practice. There was another concept which was eye-opening for me, was that the fact that HLA-B27 has many isotypes, and 2704 is associated with disease and 09 is not, and how these two behave differently, how these molecules aggregate and how they are removed by the body determines the risk to develop ankylosing spondylitis. And this is probably a very interesting paper which has actually come, I think, from the Department of Immunopathology at PGI Chandigarh, and is a very important research area and will excite people in this field. Vasculitis, as it's Dr. Nanda's favorite, received a lot of importance in the conference, and especially the young people, who showed us that a lot of important biomarkers are being studied and have proven their merit in different aspects of vasculitis, some in large vessel vasculitis, some in small vessel vasculitis. And Dr. Ruchika said that angiopoietin 2 differentiates active Takayasus from stable Takayasus. And many such molecules have been talked in the past, especially Pentaxin 3 and CRP and ESR and so many. So we'll have to see which way this field goes. IL-18 is being talked about in many ways. Increased levels of IL-18 are present in patients with active Takayasus. IL-18 gene polymorphisms are associated with Takayasus arthritis, and so this also needs consideration. Then there have been studies which have been talked about B cell populations which can be useful to predict responses of patients to rituximab in ANCA vasculitis. And the very great translational low-hanging fruit, the neutrophil lymphocyte ratio, which we know is being used in COVID extensively, which we also use, though not, which we also use in deciding if our patients with lupus who have fever have it due to infection or disease activity. But the paper which was mentioned and which was promising was that this ratio is very important for predicting GI bleeding and severe GI involvement in patients with henoch-Schönlein purpura. The same sort of strategy of Dr. Dhanda to look at these molecules and then place a translational talk next to it led us to a lot of inputs on IL-6 and P40 IL-12 as markers for Takayasu arthritis, and a great talk in which we were told that there were differential upregulations of pro-inflammatory cytokines which were very clearly demonstrated. So the IL-1 pathway was upregulated, the IL-1 receptor beta was also upregulated, and GM-CSF and JAK were potential new targets. And it was also shown that temporal artery biopsies of patients with GCA had different types of phenotypes. If you looked at the sites of tissue destruction versus the sites of intimal hyperplasia, and these differential macrophages had different immunohistochemical biomarkers and may again be used in the future for targeting for macrophage inhibiting therapies. GM-CSF has already reached a phase 2b trial in giant cell arthritis and is to be looked at in the next few years. We had a major talk on the macrophage monocyte inhibiting factor, and what was interesting to me was that while the talk was labeled as a marker of innate immune responsiveness, it also talked a lot about glucocorticoid regulation and how this pathway in which the monocyte macrophage inhibiting factor works on the innate immune cells as well as the glucocorticoid pathway, how it can be manipulated to give us agents which would help us in reducing the dose of steroids, and while at the same time maintaining the responsiveness in the innate immune system. So this, I think, is something which the DM students would love as a topic review for understanding better. A very great area of everything ultimately coming to inflammation. So OA is an inflammatory disease, and the osteoporosis that we see in inflammatory disorders is also can be tackled through anti-inflammatory pathways. So why people who have a high endemicity for helminths do not develop inflammatory disorders and how that can be used. So a product from a helminth was shown in vitro to inhibit lipopolysaccharide induced cytokine release while not doing anything to the body's own immune system. And so Dr. Naivedya talked about how biologics, what was the evidence from trials on RA about bone protection with the use of biologics. So targets in osteoporosis away from the traditional pathways were discussed. So isovastaxin was mentioned as a plant derivative which is basically a sort of an anabolic pathway and has been shown in a paper from India to be able to improve the osteoclast function, or is osteoclast inhibitor and may be used in therapy of osteoporosis. I attended this talk this morning by Dr. Shivarai Chaudhary. It was a very, very comprehensive talk and a huge talk on his journey through this field of psoriasis. And he talked about T effector therapies in psoriasis, spondyloarthritis, and he talked about different pathways. And what was interesting was that he talked about the fact that we all know that the naive patients respond very well to simple drugs like methotrexate, but as disease goes, and if you are dealing with a patient who is not going to go into sustained remission, then this patient doesn't start, he feels the need to take more and more biologics, and you change biologics. And so he hinted at the fact that there will come a time when we will be able to personalize medicine and study the temporal response of cells in a patient at a point of time, what major cytokines is the patient's cell secreting, and then decide, okay, this is the biologic that I'm going to give him. He didn't say it in so many words, but the kind of experiments that he has been doing over the last 25 years and the kind in which the field has evolved, that we have moved from anti-TNF therapy to anti-IL-17 therapy against an IL-17A, IL-17F, a combination of IL-17A and F, and then dual antibody therapy where you are using antibodies directed against both TNF alpha and IL-17A. So I think it's a very exciting place where we all are, and I really thank Dr. Danda for giving me this challenge so that I felt a lot improved after going through this exercise. Thank you very much.
Thank you, Dr. Lija. It's just a very targeted way of covering osteoporosis, OA, RA, Sjogren's, and Scleroderma, SLE, and whatnot. She covered almost all rheumatology chapters, and this is informative. From basic science, it has to go to convert into clinical course. So next conference, how this some of the controversy gets evolved and to become clinical practice in 23 Iracon, we'll see. Any questions? We are running short of time because people have to go to airport, likely to take a long time. Rajiv Gandhi Jodo Yatra is there, so it's taking a long time. People be prepared to go instead of 1 hour before, 2 hours before.
I was the only person sitting in that session. This was done at 8 o'clock. And since such a large crowd of young people are sitting, the ultrasound, that was the only paper in this whole conference which was an ultrasound of parotid. Now look, this was presented by a youngster. I also sent a poster. I had sent a paper which was accepted as poster. So I was a little unhappy. But when I saw his work, it was definitely better than me. Ultrasound of parotid is very simple to do by a clinician, probably much simpler than so many MSK ultrasound. That paper shows that lip biopsy, really this ultrasound of parotid can replace a lip biopsy, because I am doing for last 2 years. I had sent an abstract which was accepted as a poster, but this paper, probably who has not listened should be also listed there. Very important paper from Lucknow KGMU.
Thank you, Dr.
So can I?
Yeah, please, Dr. Lija.
Sir, Dr. Vechadurthi, I completely accept that the miss. It was a wonderful paper. I had the luck to be sitting in that hall, and it was a very well done paper and brilliantly executed with very good findings. And I'm sure you'll hear more about that work subsequently.
Any other comments, questions? Some matter, some paper, message not covered by Dr. Lija, you can also tell. If there are no questions, so then kindly give big hand to my colleague Ashok Kumar and Dr. Lija Rajshekar and Dr. Parashar for doing excellent work. With this, the conference scientific part of the program gets concluded. Now most important session is the next validity function, which will be taken care the responsibility of President of Indian Rheumatology Association, Ramnan. Before that, as a chairman of Iracon 2023, and my other colleagues, Lija Rajshekar and Chairman Scientific Committee, the corpus are sitting beside me. Love to invite all of you to Hyderabad in the month of December. And December is very pleasant weather of Hyderabad. Among all the months, December is the most pleasant. November. In the month of November 2023, and the weather among all the 12 months, December is the most pleasant. It's a bit cold, but not very cold like what you see here. But unless the global warming, any change in the weather occurs, you definitely communicate. And what all you want, kindly communicate to us. The scientific part, the local logistic part, anything you want, kindly communicate to us. I am mainly interested, rather than going a presentation routinely, what are our clinical dilemmas, doubts, concepts in the caring the patient, writing a paper. Kindly, coolly sit down, note down, and communicate to us. We make after we make the scientific program first, then we identify who can deliver the goods for the scientific program. We go, always I go like this. I don't choose the speakers first, then make the scientific program. I make the content of scientific program. Then I identify the personally we can deliver those goods. That's why we make it. And I request all you people's blessings for making the scientific and organizational work at Hyderabad successful and fruitful and a happy ending, and strengthen our IRA further. And with this, the Gauraprasad, you can have some comments. Then we conclude. Thanks to all of my colleagues and Iracon and IRA and local RM committee who have taken a lot of pains. And I leave podium to our president to take further responsibilities.